Hi, I'm Molly Regelmann. I'm one of the pediatric endocrinologists at the Children's Hospital at Montefiore and Albert Einstein College of Medicine. And I will talk to you a little bit about adrenal insufficiency screening in ALD today. There we go. So we'll go over how adrenal insufficiency develops. We'll talk about signs and symptoms that you can look for. And I want to make sure you understand adrenal surveillance and how we treat patients with adrenal insufficiency. So first is just to understand how it develops. So normally we have the adrenal gland, which sits on top of the kidney, makes a hormone called cortisol. Cortisol is important for keeping your blood sugar normal and your blood pressure normal, normally, especially under stress. When there's enough cortisol around, it feeds back to your pituitary gland. The pituitary gland then turns off and stops making the hormone that stimulates the production of cortisol called ACTH. In patients who have ALD, the problem arises with the very long chain fatty acids accumulating into the adrenal glands and causing an inflammatory response that leads to problems producing cortisol. Oops, excuse me. Oh, my slide went off. Problems producing cortisol, so cortisol does not get produced. The levels go down, and because there's not as much negative feedback, the ACTH levels will go up. Oh, there we go. Okay, so cortisol goes down and then ACTH levels go up. And it's important to understand this, that when the adrenal glands aren't working, the ACTH levels go up, because this is how we do screening. So what are some of the signs and symptoms of adrenal insufficiency that you should be aware of? So chronically, if a child is not making cortisol well, or adults, they will get fatigued, they'll have poor weight gain, or they'll start to lose weight. They'll complain a lot of belly aches or stomach aches. They'll have darkening of the skin, particularly in areas where there are creases or previous scars. And later on, sometimes slow development of secondary sexual characteristics like hair growth. Acutely, adrenal insufficiency is potentially dangerous, and often this occurs at times that a child has an infection, and they'll present with severe abdominal pain. They'll have nausea, vomiting, they can get dehydrated, they can have low blood sugars, low blood pressure, altered mental status, and that is an emergency that needs to be dealt with. I have a couple of pictures of the darkening skin that you can see. These are people from the same family, and you can see this is a man who has developed adrenal insufficiency and has darkening of his skin compared to the lighter skin of the family members. Darkening in the nipples and in the mouth, on the tongue and gums is very common as well. So that's just sort of a background of what happens with adrenal insufficiency. What you need to know for ALD is newborn screening and how we do surveillance. So once a boy is diagnosed with newborn screening, we've put together consensus guidelines, and by we, it's me with several other pediatric endocrinologists. I know Dr. Miller was on our group earlier today and is with us today, but those of us who had an interest got together and looked through the literature of what we did and didn't know, and came up with guidelines for trying to establish how to look for adrenal insufficiency in children with ALD. So the tricky part of all of this is that under the age of 1 and really under 2, it can be a little bit difficult to measure ACTH and cortisol and to interpret those results, which I'll talk about in a minute. So under the age of 1, my approach is generally to give parents options to either just do an initial blood draw or if travel and coming back to the office can be challenging, to give them the option of doing a stimulation test in the office, because we often find that under one, the values are difficult to interpret. Starting after one, usually my approach is to do a morning blood draw and then to determine whether or not any additional testing is needed. And then we start treatment with hydrocortisone when the levels of ACTH get high and the cortisol is not responding appropriately. The reason why it's tricky to interpret test results in infants is that infants do not have a regular, predictable way of secreting ACTH and cortisol. So normally in older adults and children, you will see normal patterns that are predictable for ACTH and cortisol, where they rise early in the morning and cortisol tends to peak around 8 o'clock in the morning and then predictably go down through the day. Infants also tend to just have lower levels of cortisol because they don't have a lot of stress in their lives, and the protein that binds cortisol tends to be low in infancy. So for all of those reasons, it's a little challenging, and it's important to have an endocrinologist to help with interpretation of results for any newborns who are diagnosed with ALD based on newborn screening. When to start and how frequently to screen is also something that's been debated. Our guidelines that we have published suggest that in the under 2 group, because it's challenging to determine signs and symptoms, that we check a little more frequently, around 3 to 4 months for testing, and that after the age of 2, where it's easier to identify symptoms, that screening's done every 4 to 6 months. There's a big complicated algorithm. This is published and available online, but I'm happy to share links for anyone who has questions afterwards. This algorithm, as I said, is a little complicated, but it's really intended for pediatric endocrinologists to have a guide when they're interpreting what to do next for test results, particularly in those under 2. And I also just want to point out that newborn screening has been very successful, and that in that it has identified boys early on who have adrenal insufficiency, and these boys have remained healthy and not had any adrenal crisis or been particularly sick, because we identified that they weren't making the cortisol well, and we gave them hydrocortisone early on so that they didn't get sick, which is really great. In terms of treatment, treatment is standard for all adrenal insufficiency, and for children, we use hydrocortisone tablets or sprinkles, or sometimes compounded hydrocortisone that's given 3 times a day. Stress dosing with hydrocortisone needs to be administered whenever a child has fever, and parents and caregivers need to be trained on how to give emergency medication, including an injectable version of hydrocortisone. Most boys with ALD early on do not have problems with holding onto salt, but that is something that can develop over time and does need to be monitored for. And there are a few boys who will need to also be treated with another hormone called fludrocortisone to help them retain their salt. And then generally speaking, we do not replace the androgens, which are another hormone that's made by the adrenal gland that the very long chain fatty acids can interfere with production of. Long-term, any child on steroids needs to be monitored carefully. If you're getting too much, you cannot grow well. If you're not getting enough, you also don't grow well because you don't gain weight well. You also have to monitor for signs of too much hydrocortisone, which can cause excessive weight gain, high blood pressure, bone loss, diabetes. But if the replacement is appropriate, hopefully you don't see any of those problems. And then I would just also point out that there are other there are medications that, if started, can alter how the body handles hydrocortisone. And so if starting other medications, particularly anti-seizure medications, it's really important to monitor for how well the child is handling the hydrocortisone. And then finally, I just would say that having emergency plans and regular plans are important. This is just a sample from a publication that actually Dr. Miller was the first author on, of how to have a plan for daily and sick day management. Each center usually has their own forms that they fill out, but you should get from your endocrinologist a plan for how to manage daily and sick day management. And there are other things that we recommend, including wearing medical IDs and having 24-hour access to an endocrinologist. And this is just a picture of the Solucortef vial that is recommended because it has both the powder and the liquid for mixing all in one place. And I usually recommend to my patients that they have like sort of a go bag that it goes wherever the child is, that includes the emergency medicines, as well as extra oral medicine in case there's just a fever, as well as an emergency instruction sheet, which I also tell parents to have. And this instruction sheet is not for parents, but for emergency room doctors and medics, so that they understand what the child's condition is and what they need to do to start treatment while they're waiting for the doctor to return the page. And then just one last thing for anesthesia, it's really important to make sure that for any general anesthesia that extra hydrocortisone is given. And this is a publication out of Minnesota where they included boys and men with ALD and kept track of how well they did with their standard protocols, and they found that they had no significant events related to adrenal insufficiency out of 166 encounters, just by following a very simple standard protocol. And lastly, I just would say that at this time, there are no therapies that are known to alter adrenal insufficiency progression, although there are some publications suggesting that maybe Lorenzo's oil might have slowed down adrenal insufficiency progression. That I would just say is an open label trial. It's not well founded. And as far as we know, stem cell transplants do not alter adrenal insufficiency or reverse it. And there's no data at this time regarding gene therapy. All right, and I'll turn it over to Dr. Tritos. Let me just stop sharing. And I'll be around for questions at the end.
Thanks so much. I'm Nick Tritos. I'm an endocrinologist at Mass General in Boston, where I see patients with pituitary and adrenal conditions. I would like to thank the organizers for the invitation. Of course, ALD is very dear to me. And what I would like to do in the next few minutes is go over some data regarding the natural history of adrenal insufficiency in patients with ALD. So here's my disclosure slide. And this is based on a study that we did a few years ago. This was a collaboration between Mass General and Amsterdam, the academic medical center. So Dr. Florian Eichler and Dr. Mark Engelen were the leaders of the study, and I was happy to participate as a collaborator on the endocrine side. So the questions we were trying to address were essentially, how often does adrenal insufficiency develop in boys and men with ALD, and what is the timing based on our data, and then try to identify whether we can find out something about what may influence the risk of developing adrenal insufficiency in these patients. So what we did, it was a retrospective review of the data from Amsterdam and MGH, which means that we looked back in the past and identify information about our patients. So we did not follow patients over time, but we just looked back. And essentially, these were patients, both boys and men with ALD, who were followed between 2002 and 2016. In total, there were 159 patients, including 86 at MGH and 73 at Academic Medical Center in Amsterdam. As you can see, at the time of the last follow-up, the median age was 24 years, 40% were children, and you can see that 71% had adrenal insufficiency, about 42% spinal cord disease, and then about 53% had cerebral disease. The fatty, very long chain fatty acid ratios were elevated, as you would expect in these patients. So what we did here are some, first of all, some baseline information about differences between the two centers. You see one column here with MGH, and the other one is AMC's Academic Medical Center from Amsterdam. First of all, it's interesting to note that there were more children. 57% of the patients were children at MGH as opposed to 20% in Amsterdam, and that probably reflects referral patterns. There were the presence of adrenal insufficiency was equally frequent in both centers, but note that spinal cord disease were more frequent in Amsterdam, and that's likely a consequence of the fact that the patients were a little older, because this develops usually in adult life. Cerebral disease was actually a little more frequent at MGH, and I think that may reflect referral patterns, actually. So here's what we found. 113 patients had adrenal insufficiency diagnosed at the time of the study was conducted. And interestingly, 67% of them had symptoms. The others were diagnosed based on endocrine tests, as Dr. Regelmann discussed with you. So it is clear that many of these patients can develop endocrine abnormalities before they develop symptoms. So it is very important to monitor adrenal function in these patients, even though they don't have symptoms. They need to be followed for the potential development of adrenal insufficiency. Conversely, in about 37% of our patients, adrenal insufficiency was the first manifestation of ALD. And you can see that there was on the average, there was a diagnostic delay of 3.5 years between the onset of symptoms and the diagnosis of adrenal insufficiency, which I think underscores the message that adrenal insufficiency can be poorly recognized in some patients. And therefore, we all have to be keen on recognizing some of the symptoms. Not surprisingly, the vast majority of these patients were taking glucocorticoids, 93%. The dose was 10 milligrams per meter square per day. This is about average, but notice that there's a wide variation. Some patients were treated with much more higher doses. And we don't really know why. We didn't look into that. That was not the purpose of the study, but certainly such high doses do raise concern that these patients may suffer some of the adverse effects. Mineralocorticoid replacement, that's fludrocortisol, also known as Florinef, was taken by only 51% of patients. You can see the dose is very typical. And we looked at the prevalence, the risk of high blood pressure and obesity in both children and adults. And I think you can argue that in children, about 15% had obesity. In adults, only 12%. I'm sorry, this hypertension, 15% had hypertension, whereas 12% in adults. Regarding obesity, 28.9% of children had obesity as opposed to 10% of adults. So these numbers are relatively high for children. I don't think they're really high for adults, but I would suggest that they're likely a little high for children, suggesting again that some patients may have been treated with higher than desirable glucocorticoid doses. So that's an area of concern, as Dr. Regelmann also nicely showed you. These data and curves show the development of adrenal insufficiency in ALD over time. Here you see the proportion of patients developing adrenal insufficiency on the left, and about 46.8% of these patients were developed between ages up to age 10, from between life. Actually, the youngest patient was 7 months. I believe there's even a 5-month-old reported, but up until 10. So the risk seems to be highest in childhood, a little lower in older patients between 11 and 40, only about 28.6% of them developed adrenal insufficiency during that time. And over 40, the risks seem to be lower, still existent. And I think this is important information because it suggests really that we should be very, very vigilant in children and younger adults. We also should be looking in older adults, but nonetheless, the frequency of our assessments should definitely be higher in younger patients. And this is shown graphically here. These curves show the proportion of patients who are free from the disease or free from medication. So as the patients develop adrenal insufficiency, the curves go down. So the blue curve shows the proportion of patients who are free from adrenal insufficiency. You can see by age 14, about half of them, of those who were to develop adrenal insufficiency, developed it. The red curve shows the proportion of patients treated with glucocorticoids, and that's closely parallels the patients with adrenal insufficiency. And then the green curve shows the proportion of patients receiving mineralocorticoid replacement, which is much lower. Again, it underscores the fact that not everybody with adrenal insufficiency needs to take fludrocortisone. These curves here show the rate of development of adrenal insufficiency in blue, cerebral disease in red, and spinal cord disease in green. And again, this is the proportion of patients who are free from the disease at any given age. I think the message here, without going into the technical details, is that it happens quickly. Adrenal insufficiency happens very quickly in childhood, and then the risk seems to be getting somewhat lower in adult life. Cerebral disease also seems to be highest in early childhood, and then it kind of goes down a bit, but still continues throughout adult life. Spinal cord disease follows a different pattern. It really starts around age 20 or so, and then it continues throughout life. I won't go into this in any detail. We try to look at the possibility that the very long-chain fatty acid levels and the ratio specifically could tell us something about the risk of developing adrenal insufficiency or even neurologic manifestations in our patients. And we could not find any evidence. Essentially, we could not associate the two. And I think the message is that we don't really understand why some of our patients develop adrenal insufficiency and others don't. Most of them do eventually, but not everybody does. And I think this is an area where ongoing research is needed to help us understand the pathophysiology, the mechanisms that drive this better. So in summary, about 71% of patients with ALD develop primary adrenal insufficiency. On the average, the age of diagnosis was 14 years. Clearly, more intense evaluation and follow-up for the development of adrenal insufficiency is warranted in childhood and adolescence than in adult life, but adults are still at risk. There was no evident association between the clinical manifestations of ALD and serum very long-chain fatty acid ratios, again suggesting that we need to do more research to understand why some people develop adrenal insufficiency and others don't. And of course, there are limitations. This is a retrospective design. We did not follow the patients over time, but this would take many years. And I think in the future, as widespread newborn screening becomes available, we will get there. And of course, our study did not have data in women, and this is also an area of interest. So I would like to stop here and happy to answer any questions. Thank you so much for your attention. This is our team, Mass General and Academic Medical Center. Thanks again.
There were just a couple of questions. I know we're at the end of the session. I will be in the newborn screening session later also to answer more questions. There was a question about 3 times a day dosing for hydrocortisone versus 2 times a day dosing, and questions about prednisone versus hydrocortisone. To answer the question about 3 times versus 2 times a day, I generally find most of my patients need 3 times a day dosing, that when they skip afternoon doses, they feel it and they feel tired. But there are some people who seem to tolerate doing twice a day dosing. Definitely during times of stress though, that twice a day dosing is not sufficient. And I recommend my patients take every 6 hours doses of hydrocortisone when sick. I don't know, Dr. Tritos, you treat older adults, so I don't know if you have any feelings on that.
So the question is about using the hydrocortisone 3 times a day or twice a day. Is that
Yes.
primarily? Okay, yeah, thank you. In adults, most adults take it twice daily, but I do have, and that's primarily because of convenience. It's more convenient to take a medication twice a day than 3 times a day. There are some patients who acknowledge that they feel better when they take it 3 times a day. So I think it's important to individualize and have a close discussion with a treating physician, and try different approaches to see what works best for an individual patient.
The other questions were just about prednisone and hydrocortisone. My preference generally is for hydrocortisone over prednisone. In the pediatric world, we almost never use prednisone until kids are done growing. And even then, I try to discourage it just because I think there are benefits to hydrocortisone in terms of bone health. And it's a little easier to prevent the obesity and hypertension concerns that sometimes come up. I don't know if you have more experience. The question was more about that. And then it just said we should be wrapping up. But again, we'll try to answer questions as much as we can stay and answer questions for anyone too.
Yeah, I agree, and thank you. I agree that hydrocortisone also gives a little bit of mineralocorticoid activity, so a little bit like Florinef. So I think that can be helpful for many of these patients. So I would prefer it, but I think again, having an open mind and trying different things may work better. So, so thank you so much. I would like to thank you all for your kind attention, and do we have a time for one more question, Dr. Regelmann?
Yeah, I was going to say the last question just was, are boys in the study given hormone replacement before being diagnosed with adrenal insufficiency? So I'm not aware of anyone doing that. Your study, I don't think everyone was diagnosed with, it was a retrospective study, but everyone was diagnosed with adrenal insufficiency and then put on treatment.
That's right. That is correct. All right.
Thank you, everyone.
Thank you so much. Thank you, everyone. Thank you. It's a pleasure.